All right, I think I'm ready.
There we go.
Good.
Good.
All right, everyone, thank you for bearing with us. And it's not a virtual summit without a few technological issues, so I appreciate your patience. It is our huge pleasure to introduce Dr. Eric Forno, who is going to be speaking with us about obesity and childhood asthma. So without further ado, I'd like to kick it off to Dr. Forno. Thank you for being here today.
Absolutely, thank you. So let me make sure I have the right screen. And all right, so first I want to thank the opportunity to be here virtually with you and talk about something that I've been interested in since fellowship. So I want to thank Carolina. I want to thank Dr. Perpich. I want to thank the organizers in general and everybody in the audience. Thankfully, we have the technology to do this, even though we're not necessarily all in the same room. So before I begin, no commercial or other financial conflicts of interest for this talk. And I wanted to go through really quickly through some of the objectives. The main three objectives I would say would be to examine some of the evidence for why obesity matters for asthma or for our patients with asthma, to review some of the research into the underlying mechanisms for this association. And then the third part will be sort of try to go through some of the recommendations on how to manage these patients. Now, I'll go quickly so that we can have time particularly for the management portion and also for questions. And at the end, if anybody has any questions or if they want to contact me offline, I'll be happy to do so. But don't worry too much about every single figure in every slide. It's more to try to make some of the points. So hopefully the information will be helpful. So I'll start again. I always present this patient that I've called Daniela, who I actually saw in fellowship, and she was one of my patients in fellowship. And that's one of the reasons I became interested in obesity and asthma. When I saw her in my first to second year of fellowship, she was 11 years old and was sent to us for asthma that was not well controlled, had 6 ER visits and 2 hospitalizations in the year before. And she was on albuterol as needed and Flovent 110, and she was taking two puffs once a day, and the PCP sent her to us for further management. And so over the next few months, we saw her frequently and escalated her treatment to the 6 medications you can see there. So we went up to Advair, we added Singular, continued the albuterol, added antihistamines, PPI, Flonase, and she was still not quite where we would like her to be for that number of medications. She still had some faint expiratory wheezing. Lung function was not quite normal. In that subsequent year, she had fewer ER visits and hospitalizations, but still I thought that 1 and 1 were way too many for the amount of medication we were giving her. We also ruled out other things, make sure that we were not just treating something that wasn't the whole picture. And we also, of course, remember that it's not all about medication, so we did environmental modifications and asthma education as well. Still, she improved, but not as much as I would like her to be. And the only thing that I could think of was this BMI that was elevated, so she was obese. And I had read some papers about an association between obesity and asthma. And then what happened was, you see here in red is her BMI. And because at that point she was 12 to 13, she decided she wanted to lose weight for other reasons, not for her asthma. And you can see her BMI started to go down. And here in blue, you see her FEV1. These are the 2 courses of prednisone that she had during that year that I took care of her that first year. And you can see that she responded to prednisone, but then as soon as that went away, we were stuck there with an FEV1 FEC of about 72, 73%. But then when her BMI started to get better, so did her lung function. And so she's just an example, but I saw several patients like that who had obesity. And the more I read, I found that there's this association that have been reported on obesity and asthma. These are studies from several years ago now, where you can see the prevalence on the left in adults and in pediatrics on the right side on how the prevalence of both obesity and asthma has increased sort of in parallel over the last several decades. Moreover, there were papers, I guess this was now 15 years ago, but even back then I had read this paper where there was this meta-analysis of longitudinal cohorts where early obesity led to later incidence of asthma. So obesity preceded the development of asthma, and the relative risk was about a 30 to 40% higher in those who were obese. We then worked on this meta-analysis where we looked at maternal obesity, and that was also associated with a higher risk of obesity in the offspring. So something even early on, I think the problem was that something started early on in utero. So it wasn't just necessarily, sorry, I lost my, oh, there we go, my pointer. Something happened early on, and so it wasn't just a mechanical effect of obesity. And we wanted to better understand why. And so through the years, several groups, including ours, have looked at different studies in terms of obesity and asthma. And we know from several epidemiological, longitudinal, experimental studies that there's higher risk of asthma in people who have obesity. And then among those who have obesity and also asthma, they tend to have worse asthma. They have more frequent symptoms, they have poor control, they have longer, more difficult to treat exacerbations. They don't respond to asthma medicines as well. And therefore, all of that, of course, leads to lower quality of life. This is a study that I published when I was still in fellowship, and the idea had nothing to do here with obesity. We just wanted to have a clinical score that primary care providers could use when they were screening patients with asthma to see who was at high risk of an exacerbation. And so the idea is that they would just do a quick checkbox list, and they could calculate if there was low risk or high risk of an exacerbation. And what was interesting here, you can see the score, the distribution of the score was nice. And then you could see behind that racing bar it went all from like 0% hospitalized to 100% with a severe exacerbation in the higher ends of the score. So it seemed to work. But what was more interesting is when you had the patients that had in the same severity score or exacerbation score, if you then broke them down by BMI, you could see here the odds ratio for everybody was around 7. But if you break them down by BMI, those in the 80% category or more, they had almost 17 times higher odds of ending up in the emergency room or in the hospital, even though they had the same clinical score. So even sharing the same other risk factors, for some reason, these kids with obesity ended up in the hospital more frequently. And so we'll talk about some of the proposed mechanisms. I listed 4 or 5 here that we'll go through. We may end up skipping genomics depending on the time. There are a lot more, but I thought these would be sort of representative of why this is a relationship that's complex, which makes it interesting to research, but not necessarily interesting for our patients and us when we need to manage them. So the first was another study that we did a while back was, again, on decreased inhaled corticosteroid response. And for this, we used data from CAMP. For those of you who remember, that CAMP was a clinical trial that went on for 4 years. It recruited over 1,000 kids from 8 centers in the US and Canada. And there were 3 arms that later on were combined into 2. Basically, budesonide as a steroid, and then nidocromil and placebo. There were really no changes with nidocromil, so subsequent papers always grouped these 2 as placebo. And so all we did was reanalyze this data from that paper that was published in the New England, and I think it was the year 2000 or 2001. And we just stratified the patients in the trial by their weight status. And so here on the left, you can see normal weight, in red or pink, the placebo arm, and blue, the budesonide corticosteroid arm. And there was a clear improvement in FEV1 throughout the 4 years of the trial. In the overweight and obese, we saw some improvement first, and then that got lost after about 12 months. There was no further improvement. More importantly, when you look at FEV1 FVC as a marker for obstruction, you can see the clear difference, right? So the patients with normal weight got better. Those who were overweight and obese did not show any improvement, despite participating in this clinical trial with very close follow-ups, which we know is much better than what we do in real life. And that also led to increased exacerbations and prednisone. And so people started to try to figure out why these changes, or why they were not responding to medications and they were getting sicker. And as often happens, the first literature that we had was from adults. in which they thought, well, maybe, you know what, there's this extra weight on the thoracic cavity and the respiratory system in obese, and maybe that's compressing the lungs. And then it also can compress the airway so that the airway smooth muscle is not nice and relaxed, but it's sort of crumpled here and what we call airway smooth latching that makes it more difficult for it to relax. And indeed, there were studies in the 2000s where you could see that as BMI increases in adults, FEV1, FVC was normal, so no signs of obstruction, but there was clearly a decrease in the lung volume. So the lungs tended to be compressed, or what we think of as a restrictive deficit. However, the problem was that we didn't see that in kids, right? So that we had unpublished data from back then, and there were also some other published studies that showed that actually in children, the FEV1 FVC ratio did decrease with increasing BMI. So there was something that looked like obstruction. And so clearly adults, children were not just small adults, there was something different here. What we saw in several studies is this decreased FEV1 FVC ratio, but they also, in my experience at least, they tended to have higher FEV1 FVC. So we couldn't really call it obstruction if they had supernormal FEV1. And so then we came with this, we came across this concept of dysynapsis that was first described in the 70s, where there's some sort of incongruence or asymmetry between the area of the airways, the caliber of the airways, and the volume of the lungs. And the way I think about it is this way, right? So this is an oversimplified model with one airway and one big, large volume lung. And the resistance in the airways depends on the squared of the radius, whereas the volume depends on the cubed, the radius cubed. And so if you just symmetrically increase the size of this, the ratio is going to go down. So it's going to look like there's an obstruction, even though they're exactly the same in terms of the resistance and the volume. And so that's what I thought was happening with obesity. And so we hypothesized that kids with obesity may have more of this dysynapsis, and that may lead to some of the findings that we saw. So we started with our cohort here in Children's in Pittsburgh, looking at all the data from our PFT lab. And then we ended up adding 5 other cohorts, looking at dysynapsis, defined as supernormal FEV1 FVC, but a low ratio. So it looks like obstruction, but not necessarily. And here are the cohorts that we used. And what you can see here is when we had about 4,500 kids, of whom roughly 1,200 had dysynapsis. And so either looking at BMI Z-score or categories of overweight and obesity, these children had twice as much odds of having airway dysynapsis. If we looked at it longitudinally, the kids who were always obese versus the kids who were never obese had 4.3 higher odds or fourfold odds of having this airway dysynapsis. And so we saw this phenomenon consistently in these cohorts. What was more interesting or important was that inhaled corticosteroids didn't change this relationship. And these patients with dysynapsis had higher risk of exacerbations and from requiring prednisone. So something in the anatomy or the development of these patients was leading them to look like they had obstruction, was associated with more symptoms, and was associated with more exacerbations. Probably not related to necessarily inflammation, and that's why corticosteroids were not making any difference. So now we're working on a couple of projects where we're trying to look at measuring airway dysynapsis using airway CTs to see if we can actually quantify that and see if that hypothesis is really true or not, right? So look at spirometry, we want to look at the anatomy. So another important topic that people have debated is whether it's inflammation that's atopic or non-atopic. And another thing we won't talk about today is whether this is just airway inflammation or more systemic inflammation, right? So in obesity, part of the reason why we end up with cardiovascular disease and other complications is because there's this inflammatory milieu, and maybe that's what's inflaming the airways, which is different from our primary airway inflammation that we see. So in any case, there have been studies that have shown that obesity is associated with less airway inflammation, but there are other studies that have shown that obesity is associated with increased allergic sensitization. So maybe when you're not looking at the airways, but at the blood, there's a relationship there. And there was a study here from the 2010s that looked at NHANES data and looked at the relationship between BMI and the probability of asthma. And even though it was positive in both, it was much more significant in the non-atopic kids. So we did the same thing. We looked at data from NHANES, roughly 2,600 children and adolescents, and we wanted to look at exhaled nitric oxide as a biomarker of eosinophilic inflammation in the airways. And this is what we saw. In patients that had high FeNO, so higher inflammation, eosinophilic inflammation in the airways, there was no relationship between obesity or BMI and asthma risk. Whereas if you looked at those who had normal nitric oxide, that's when you saw twofold and fourfold odds of asthma in this nationally representative cohort. So again, going back to the fact that maybe some of the obesity component in asthma is non-atopic and it's a different type of inflammation. However, if you do have high exhaled nitric oxide and asthma and you're obese, you end up in the emergency room or you end up missing school days much more frequently. So clearly, there's also a synergistic relationship there. We saw the same thing in another study where we looked at obesity and rhinitis, where the results were all driven, the association between obesity and rhinitis was all among the non-allergic rhinitis patients. So it is certainly a complex relationship. That doesn't mean it's the answer for every population. There are clearly indications that maybe this is not just your classic type 2 eosinophil-related inflammation that we see in most of our atopic asthma patients. We also looked at insulin resistance and metabolic syndrome, again, under the premise that there is a rationale that some of that insulin resistance and resulting inflammation is what leads to the complications of obesity. And building on some basic science data showing that metabolic changes can actually affect the airway smooth muscle, can cause epithelial damage, and can cause some degree of collagen deposition and airway remodeling. So we wanted to look at that. And again, we ended up using data from NHANES with a hypothesis that insulin resistance would affect lung function in adolescents, even if they didn't have asthma. And so that's what we try to look at. I'm not an endocrinologist, so I looked up these different indices of insulin resistance, and this is how I remember. The glucose insulin and the quickie ratios are good, so we want them to be higher because that means better insulin metabolism. Whereas HOMA-IR is a marker of higher insulin resistance, so that's the one we don't want it to be high. And so when we did our analysis here, you can see this is lung function on the left in all participants, in participants without asthma and participants with asthma. And you could see that, of course, as we had higher indices of the good indices, lung function was actually higher. And this was more pronounced in the kids with asthma. And then the bad index was associated with lower lung function. And the other interesting thing is that metabolic syndrome was associated. Remember, we had talked about the low FEV1 FEC ratio. That's what we saw in the patients who already had metabolic syndrome. And so this is what it boils down to. So patients who were healthy had a roughly FEV1 FEC of roughly 87%. Having metabolic syndrome, you drop 2 to 3 points. Having asthma, you drop to about 81%. And if you had asthma and metabolic syndrome, you were starting already 10 points lower than your healthy peers. And so, of course, the next time you get sick, if you're starting 10 points lower, you're gonna be much more likely to end up in the hospital or in the emergency room. And this is a combination of asthma, but also the metabolic derangements from obesity. And so, last on this portion on the mechanisms, I'll talk about genomics real quick. Because both asthma and obesity have a high hereditary component, people thought, well, maybe if we look at genes, we're going to find genes that predispose people to have both. And there were a couple of initial very promising studies where we found leptin and PRKCA were associated both with asthma and with BMI. There was a later GWAS with 23,000 individuals, both pediatric and adults, where DEN-D1B was associated, but that didn't really replicate in studies afterwards. So unfortunately, looking for that miracle gene that explains asthma and obesity has been a little bit disappointing. And so over the last 10 years, we've been looking at not just the genetic polymorphism, so not just the genetic code, but how that genetic code gets regulated. And so one of the things we've been looking at is DNA methylation. DNA methylation regulates how tight or relaxed the chromatin is. And so therefore how difficult or how easy it is to transcribe those genes and turn them and express them into proteins. So what happened was, though, that the majority of studies in obesity and asthma had looked, in both diseases separately, had looked at blood. And there have been studies that have shown that, of course, the DNA methylation is very different between blood and airway epithelium, right? We all share the same genetic code in all our cells, and it's the regulation of that genetic code that makes one group of our cells to turn into blood, white blood cells, and another different set of genes is activated to turn into airway. And so, of course, the DNA methylation and gene expression are going to be different. It doesn't mean that we shouldn't be looking at blood, but it does mean that maybe the airways are giving us different information, and we need to start looking there. And so for our first study that we showed, that we published in asthma, not obesity, but just asthma, we looked at airway epithelium in roughly 200 cases and 130 controls, where we had epithelium, nasal epithelium, DNA, and RNA, and we looked at whether there were differences between kids with atopic asthma and controls. And for those of you who are familiar with this, this is a volcano plot. Here in blue, you have the genes or the markers that are hypomethylated, and here are the ones that are hypermethylated. So we saw roughly 7,000 markers that were different between asthma and control. We then replicated, again, I started with a Puerto Rican cohort. We then replicated those findings in an African American and an European cohort to see if those findings were unique to our population or if they would replicate in different settings and in different races and ethnicities. And busy table, but I think the point here is out of the top 30 genes, there were 28 that replicated in this cohort and 29 that replicated in the other one. So there was really good consistency of the results independent of race, ethnicity, and environment. Most of those were associated with regulatory responses, but there were some that were also altering the functioning or integrity of the epithelium. And so that was an interesting theory that people have pushed more over the last few decades or the last few years, is that maybe there's something in the epithelium that's not working properly, and therefore that alters the immune response to different stimuli. The other thing is we were able, just using 30 of those markers, to accurately classify roughly about 88% of our cohort into whether they had asthma or not without asking them any questions, just with the markers. And then roughly 85% of the two other cohorts. And so the hope is that one day we may be able to use those markers in the clinic to try to help our diagnosis of asthma and see if it points in one direction or the other. And so right now we're starting to look at obese asthma, and we're looking at, again, gene expression in nasal epithelium to try to see if there is a signature of this obese asthma phenotype. We're looking at two different cohorts, one in both in children and adolescents, but one is a longitudinal cohort, another one is a cross-sectional cohort. And we are already finding some genes that are different in those kids who have obesity and asthma compared to the kids who have non-obese asthma. And what's interesting is none of those, or the majority of those, are not atopy related. They're more interferon signaling and other cytokines that may be associated more with innate immunity. And so we will start looking at that in more detail. So obesity is associated with higher risk of asthma. If you have both obesity and asthma, your asthma severity is probably going to be worse. You don't respond to medications as well. The mechanisms are multifactorial and complicated. It makes it great for a research career, but not necessarily for managing patients. And so we need to better understand what to do with our patients. How do we help them? And so that's when I'll focus on this second part of the talk. And I wanted to go through some of the guidelines, and this is GINA 2020. We now have GINA 2021. It's not entirely all the different, so I just kept the recommendations from last year. Over the last 3 or 5 years, GINA has now specifically talked about obese patients. If you go through the guidelines, and here's the link and you can just look them up, there are sections that state that, of course, asthma is more common in obese than among non-obese people. However, it also cautions, and this is something that we all need to bear in mind, is that respiratory symptoms may be common in obesity because of the obesity that mimic asthma, and it's not necessarily just asthma. So somebody can come, for example, with shortness of breath or dyspnea on exertion. They may even report that they feel wheezing, and it's not necessarily asthma. And so that's why it's important to confirm the diagnosis with objective measurements of airflow limitation that then reverses with albuterol. So get PFTs, get BDR, get objective confirmation that this is truly asthma. It also says that as part of the assessment of your patients with asthma, it's important to evaluate comorbidities. And among those, there's obesity. Not only obesity, but there's also a couple of other comorbidities like reflux and OSA that are more frequent in patients with obesity. So the whole package is important to think of when you're assessing patients with asthma that are not well controlled, because it can all lead to increased asthma symptoms, poor quality of life. It can also increase the risk of exacerbations. Even in patients whose asthma symptoms are mild, obesity can lead to higher risk of exacerbations. And as we said, there's a reduced response to medication, so they're not going to do so great if they do get an exacerbation. As part of the management, there was consensus and data from randomized controlled trials, so evidence grade B, that it's important to offer strategies for weight reduction to our patients with obesity and asthma. There's data in adults that even a 5 or 10% reduction in weight can lead to improved asthma outcomes. So it doesn't have to be a huge weight loss, but any weight loss can be healthy for asthma. It's also, again, important to differentiate obesity-related symptoms such as dyspnea or deconditioning or OSA before we escalate asthma treatment. And that inhaled corticosteroids are still the mainstay of asthma treatment in obesity.
How are you feeling?
Hello?
A spider on
You
your
think there's somebody
vanity.
else?
Oh.
I like looked over. I was like,
So,
Mute yourself.
oh, be careful.
Mary, can you please unmute yourself?
Technical difficulties all over the place. She's like, oh, you could tell she was
I
freaking.
think Arcadia will be better off just.
No,
Mary-
this isn't
Mary-
Arcadia. This is an
Mary.
asthma. It's the- Okay.
Sorry, Dr. Forno, you can continue.
okay. So again, ICS are still the mainstay of asthma management. So even though we should manage and keep in mind the obesity, we still should treat them as we do the rest of our patients with asthma. So we did a meta-analysis a couple of years ago where we looked at, does weight loss actually help improve asthma symptoms? And we looked at 4 pediatric and 6 adult studies. And what we found here, I'm showing just the pediatric studies, that even though the majority of these studies were relatively small and the interventions varied from diet and exercise to just diet, from 8 weeks to a year and a half, there were improvements in BMI. And there were improvements also in some inflammatory biomarkers, in asthma control, asthma quality of life, but not necessarily a lot of differences in lung function. So I think that this may have been just very small sample sizes and we need longer interventions, but there is certainly evidence that it is helpful for asthma symptoms and control. There's data from bariatric surgery, not that I'm advocating everybody should get bariatric surgery, but I think this is one way to look at dramatic weight loss and see the impact of asthma, where there is clearly improved asthma control, quality of life, lung volumes, and other measures of asthma after bariatric surgery. We then looked at whether it makes a difference whether you resolve your metabolic syndrome symptoms. And we saw that independent of the amount of weight loss, the patients that did better or the patients that did best were those whose metabolic derangements improved after bariatric surgery. Those who lost weight but still had metabolic syndrome continue to not be as well controlled in terms of their asthma. So it's not just the weight loss, it's really more the bariatric, the metabolic changes. I'll say a couple more things. One is the comorbidities. So again, important to remember, we should manage asthma in our patients. They're not just, for me at least, it's important to remember that it's not just the respiratory symptoms that I need to treat, but also important to look at the patient as a whole and make sure I manage their asthma. But also, as I mentioned, obstructive sleep apnea that is more frequent in obese patients. It can also worsen asthma symptoms. and reflux that is sort of in the same situation. So the GINA guidelines and other guidelines recommend that if you have a patient who has obstructive sleep apnea diagnosed with a polysomnogram, you should treat the OSA, and that can lead to improvements in asthma. And the truth is that we should treat obesity, the OSA anyways, right? But that can also have an impact on asthma. And so the main treatment for particularly adults with OSA is weight loss. In pediatrics, we have other reasons for OSA, such as tonsils and adenoids, but always remember we need to focus on weight as well. Reflux also, if you have a patient with clear symptoms of reflux, management of their reflux can also help with their asthma control. And if there are no symptoms, but you suspect and it's not clear, then maybe you should do a workup. But I wouldn't go around just doing empiric treatment or empiric evaluation for reflux in patients who have no symptoms. And we talked about metabolic syndrome, so I won't go into that. So unfortunately, we don't have any good obesity-specific pharmacological asthma treatments yet. There are some promising data on metformin and other anti-diabetic drugs. Statins and anti-IL-6 may also be helpful, but those are very experimental still. And so further composing the issue is that there is some evidence that poorly controlled asthma may also precede, worsen, or predispose to new onset of obesity. And so clearly it's a complicated relationship, but until we know better, it's important to follow the asthma guidelines. Don't forget to address obesity if you have it there. And it is generally good advice to eat healthy and exercise anyway, so we shouldn't just focus on the wheezing, but focus in our patient as a full person and give good advice for the future. So in general, the relationship between obesity and asthma is complicated. I think we're getting better at understanding it, and hopefully in the next 3 to 5 years, we'll also start to see more promising ways to treat these patients. So with that, I want to thank, again, this is research that is multidisciplinary and happens with a whole huge group of people. So everybody in the Pediatric Asthma Research Center in our division, our funding agencies, the hospital, and everybody that participates, and more importantly, all the participants and families and our research team members that make all this possible. So with that, I'll thank you, and I hope we have good enough time for questions. There's my email and the Twitter handle if anybody wants to also reach out offline. Thank you.
Thank you so much, Dr. Forno. We have just 3 minutes for questions, but if not, we'll make sure everyone has your email. But this was such a great presentation. And it's really great to learn more about that intersection between obesity and asthma. So just 3 minutes left, but we can take 1 or 2 questions.
Basically, hi, Dr. Forno. Thank you so much. That was very informative. And it's just as you were talking and me growing asthmatic as a child, as a Puerto Rican child growing up in Puerto Rico, it was just kind of weird to see that I grew up very skinny. And that's kind of the perception of, I remember people with asthma, they were very, very low weight, and now it's just different. It's exploded, and now we are now, because I'm on the other side now. I'm obese with asthma, so it's just interesting that, you know, decades ago, people with asthma were, you know, with low weight, and now we're not.
Yeah, thank you. I think it's certainly evolved, and I don't think obesity is the only responsible for the changes in prevalence that we've seen in asthma. Right? Clearly, there's changes in pollution and many other things. But I do think that it would be naive to think that with all the inflammation that obesity brings, that there isn't. Why should there be an impact in our arteries and our hearts and our pancreas and everything else, and not affect the airways? So I do think that we need to get better at managing that for our patients. My research is always with the hope that we'll find something that we can do for them, even if it takes a few steps. So we'll just have to see how good we get at it in the next 5 years or so. All right. Well, I apologize for finishing up late. We did start a little bit late, so that's probably where we ran out of time for questions. But again, if anybody has anything that they want to discuss, please feel free to email me or message me.
Thank you so much, Dr. Forno.
Thank you.
All right, folks, so we'll just head back to the main meeting room. So on that bottom right, you can click on the button Leave Room and leave breakout room so you can return to the main session.